Hey Kelvin, hey Ethan.
Hey,
Hey, I think we need to.
So, like Kelvin mentioned, today we'll be looking at a newly launched platform, Clinical Reasoning. Just making sure my screen is visible to everyone. Great, thanks, Kelvin. All right, so this is Clinical Reasoning, a new platform designed to help build confidence in clinical reasoning amongst students, interns, and junior doctors while they evaluate their patients and build a structured, evidence-based framework for their differential diagnoses. It helps strengthens clinical learning using problem-based thinking. It reinforces mastery of classic and uncommon presentations of different diagnoses that patients can present with using around 600 illness scripts. And it helps sharpen diagnostic skills using AI-powered patient case encounters, or what we also call PI, patient interactive encounters. We'll be looking at all of this as we go, but just starting with a short introduction on what that is. So a bit about this platform. It is guided by a preeminent editorial board consisting of physicians and subject matter experts in the field of medicine. The editor-in-chief is Dr. Scott Stern, who is a renowned medical educator with over 20 years of experience and 50 plus teaching awards. He's the co-author of the book Symptom to Diagnosis, which represents one of the main resources based on which clinical reasoning was built. And he's also a co-host of the Symptom to Diagnosis podcast. The platform was based on different authoritative trusted resources. And like I mentioned before, it is meant to enhance diagnostic skills through structured frameworks as well as practice cases. So what objectives does it achieve? It aims to teach students how to think critically and develop their informed differential diagnoses. It also provides a process that students can follow when evaluating patients to reduce reliance on traditional methods like hunting and pecking, or what we call trial and error. It also includes practice cases, which I mentioned before, the patient interactive encounters, which allow students to engage with realistic conversations and help simulate real-life scenarios. It also includes feedback reports that would help students evaluate their clinical skills and improve their diagnostic accuracy when dealing with real patients later on. Inside this product, you will find comprehensive content that covers all major adult symptoms. Like I said, there will be over 600 illness scripts, so covering different presentations, including the rare and the uncommon ones, as well as different risk factors, symptoms, signs, and workup strategies. This also includes critical alerts, which would highlight emergent or not to miss diagnoses, so students are always alert about these ones. It includes the interactive cases, which are AI-powered interactive encounters with real patient scenarios. There's a diagnostic comparison tool set, which includes different workup tables. So this would include physical examination, diagnostic workup, and more. And of course, it is all structured and evidence-based approach. So all the decision points are reinforced with algorithms that help guide symptom evaluation. I'm sure you're all wondering about the AI-powered practice patient cases or the patient interactive encounters. Like I mentioned, these are meant to practice diagnostic skills while having real-time conversations with realistic AI-powered patients. These would help engage in lifelike conversations as students or junior doctors work through cases. Of course, each case has its own presentation and its own supporting factors, including the chief complaint, the symptoms, the signs, and it is meant to support deliberate practice and diagnostic reasoning. And after users compare their decision making to expert thinking, they will receive the feedback report, which will help them in future practices and, of course, when encountering real patients. So just to summarize, each AI-powered practice patient case provides a detailed evaluation report. I'll show you an example of this later on. It helps understand what shapes the diagnosis, so how to move through the diagnostic approach, starting with history taking, then the physical examination, then all diagnostic tests, and the meaningful feedback is tailored based on what each user does. So what are the tests that I, as a user, have ordered to that patient? I will get tailored feedback. It's not a standard report for every case. And with that, we're achieving the objectives that we've talked about earlier, evaluating, sharpening skills, and building confidence. So these in more details, but what you will find there include frameworks, which are guidelines for learners to help them through diagnostic reasoning with very clear, straightforward steps. Problem modules. So for every module, we're looking at what are the focused signs and symptoms and what are the diagnostic test results that are usually accompanying that particular problem. We're looking at illness scripts, which offer concise, targeted information, evidence-based algorithms, like I mentioned before, and differentiation. So we're talking about clinical reasoning as it focuses on teaching systematic reasoning rather than providing the answers. If we go more into some of the details, again, this is evidence-based framework developed over 20 plus years, incorporating different tools and resources, including algorithms, guidelines, and approaches. The feedback covers history taking, physical exam, differential diagnosis, and appropriate testing decisions. It provides a homogeneous learning environment as it provides a consistent, high-quality framework, and this allows to reduce variability among instructors. So all the students are getting the same guidelines, the same framework, the same consistent clinical reasoning tool that they're following in their differential diagnosis. It is also easily integrated into existing curricula. So it supports preclinical courses, clerkships, residency programs, and more. And it guarantees that students or junior doctors are being exposed to critical diagnoses, especially when looking at the ones that are emergent or not to miss, and also the rare cases that might be hard to see in their real clinical rotations. And then it is modern and interactive, and everybody is so focused on how to utilize AI and the different interactive tools in today's learning. And of course, this is the preferred learning method of today's students. So when we say problem modules and illness scripts, what are we talking about? We're talking about scripts that start with a problem that patients could present with. So a patient could come in and say, I have a headache, or I have sore throat, or edema. So these are the illness scripts, and they start from something as general as a headache, and then walk users through a detailed clinical reasoning framework. So how can this product be used? Like I mentioned, it is meant for students, for interns or junior doctors, and then of course it can be utilized at an institution level. So for medical students, it really prepares them for their examinations and clinical rotations. It helps reduces the anxiety and the stress of having to deal with real patients when they only have their theoretical knowledge. It supports remediation through self-directed learning, and it leverages evidence-based questions to help reduce any diagnostic errors that they may encounter and approach the patient in a systematic framework, providing a guideline on how to make sure we're providing the best quality of care for patients. For the junior doctors or residents, it aids in managing complex cases. So again, there are cases that are not very common. They are rare. And by having these junior doctors practice through clinical reasoning, it helps improve their performance during their on-call hours. It offers advanced cases for some atypical presentations. So sometimes a diagnosis presents in a very atypical way, and usually doctors or medical students study more of the typical presentations, but using this tool, they will be encountering some atypical presentations. It also reduces the unnecessary testing. So many times when they're thinking of like 20 different diagnoses, they start ordering all these diagnostic tests. And this tool would help them use the algorithms, use the framework to narrow down the diagnoses to the most relevant ones, and then use the diagnostic tests that are specific and relevant to rule out and make the proper diagnosis. And then, of course, at the institution level, we're talking about integrating problem-based framework. So we can't talk enough about problem-based learning. This goes a step further and looks at how to fill the gaps that students in their clinical rotations or junior doctors are being challenged with, especially when it comes to their clinical reasoning training and on improving their diagnostic accuracy. It also integrates into flipped classrooms. So this tool can be used in different teaching methods, whether you're using flipped classrooms, whether you're preparing students for their clerkships, or like I mentioned before, as a remediation pathway for students who like to self-study and have some self-directed learning through authoritative, trusted tools. And then, of course, according to these points that we've mentioned, automatically this will improve student outcomes. It will help ensure that all the graduates of these institutions are well prepared and positioned as good quality care providers, and thus the institution as a leader in medical education. So these are just some of the students' feedback, students who've tried the clinical reasoning and they explored it, and this is some of the feedback we've received, especially for a newer resident or someone who does not know these questions as second nature. This tool would be helpful. Clinical reasoning would enable me to shine in medical clerkship and present in a thoughtful way. It's really helpful being able to work through a case in this way. I prefer this to memorizing paragraphs. And with that, I want to pause and see if you've got any questions before we move into the product tool.
Any questions on it? I just want to, before Yara go to the product tour, we just want to highlight any questions that you have for clinical reasoning.
他说在示范前有没有什么问题想问？可以先提，对，赶快现场，赶快示范。先示范，先示范。
可以示范吗？可以。I think Yara, I think they're excited to actually see the product first, and they will come back with questions. Maybe we can do the walkthrough. We can mute it and we can walk them along the way with the solution walkthrough, click-through video, click-through function.
Absolutely. All right. Okay.
If you can mute the sound of the video.
Yep. So we're looking at clinical reasoning product at the moment. This is how the homepage looks like. And this is a demo tool that I'm going to walk you through and explain what each module or tool is there and how we can apply all that has been introduced in the slides before. So when I log in into clinical reasoning, I land on this homepage. I can sign in to my account and I will see the welcome note here. We are basically looking at two tabs where we can start. The first one are the problems. So we're looking at different problem modules and also the illness scripts. With the problem modules, we can look at all the problems or filter on problems based on signs and symptoms or lab abnormalities. So say, for example, I want to look at problems that feature fever, for example. I can filter by the signs and symptoms, or say I'm looking at problems that also include some lab abnormalities like low hemoglobin. I can also use these filters to find out some specific problems that I want to review. The illness scripts, as I mentioned before, there will be eventually over 600 detailed illness scripts. At the moment, there's a huge number of those already there to explore and practice with. And these are associated with the problem modules. So for every problem, we have a number of illness scripts. And these illness scripts, again, they're really what include the different details on the patterns and the signs and symptoms and the different details associated with these illness scripts. So this is what a typical illness script would look like. We're looking at brainstem stroke as an example. And like I mentioned, it provides a complete disease profile with all the details. So starting with the classic presentation, then going into more of the atypical or the uncommon presentation, which students often forget about or do not come across. The pathophysiology of the disease, the etiology, the risk factors, the signs and symptoms, the workup, and more. So it really covers everything related to each illness script. And with that, it is guiding diagnostic reasoning by providing clinical insights on each of these illnesses. Now, although you can browse through the illness scripts, you can also use the search functionality here, where you can look up specific problem modules or illness scripts without having to go through the full list. As I mentioned, there will be around 600 different illness scripts, so maybe you're looking for something very specific, like acute respiratory distress syndrome or something different. Now, let's dig deep into what a problem module is and what an illness script is. So starting with the problem modules, I'm going to use the transient loss of consciousness as an example here, and we'll explore how it works in the problem module. So the problem module provides you with an overview of this problem to start with the diagnostic process. So if a patient presents to me with transient loss of consciousness, what is it that I want to look for? What is it that I want to dig deep into as a student who is learning differential diagnosis or clinical reasoning? We do have different resources here or different tabs. So we're looking at emergent and must not miss differential diagnoses. These are, again, like the name implies, either emergency situations which cannot wait, or not to miss diagnoses because they might be life-threatening. So alcohol poisoning is an emergent situation. It has to be treated on the spot. Aortic stenosis is a life-threatening situation. So when we face a patient with transient loss of consciousness, these are the first checklist that we want to make sure are not on our differential diagnosis list. This is what we first look at. Then we're looking at as well at some other possible differentials. So after we go through the most dangerous ones, if we want to call them that, the emergent and not to miss, we also have the other possible differentials, and we also have the algorithms. So what are the algorithms? This is what an algorithm looks like. It is really a decision tree that helps users narrow down through the different differentials, the different differential diagnoses or the possible diagnoses based on what the patient presents with. So if the patient presents with transient loss of consciousness, as a first step, I need to know, is this syncope or non-syncope? This is the main question that I need to start with. If it's syncope, I have to check whether it's cardiac, orthostatic, or reflex. And then accordingly, I have other tests and other diagnostics to go through. And if it's non-syncope, I want to rule out these different differentials and make the proper diagnosis. So these algorithms will help users get closer to arriving at their final diagnosis based on this decision tree. And then in every problem module, in the problem overview page, we'll also find a summary of the approach. So really providing like a step-by-step guideline onto how to approach this problem. So in here, as the algorithm really shows in a graphical way, in here, the summary of approach again summarizes the two pivotal points that I need to focus on when going through the clinical reasoning of transient loss of consciousness. First, I need to determine whether the event is syncope or non-syncope. And then it provides some like hints on when syncope occurs and when non-syncope loss of consciousness occurs. And then if it's a syncope, I need to determine the type. And then again, it provides different types and what each of these is characterized with. So again, just setting up the framework, the structure for working with such a problem. Now, from this point onwards, we can begin the diagnostic process. So after gathering the information, we can click Begin Diagnostic Process. And this is where we dig deep into what was summarized on the problem overview page. So this is walking you step by step into the evaluation of each problem, starting with viewing the different differentials and so we can start here. So in here, we're looking at the problem, the 19 focus differentials that I want to work with, and the algorithm again. Once again, we see the pivotal question here. We'll get to the practice case in a minute, but if you want to skip all this, you can, and you can directly go to the patient interactive encounter. But it's always really recommended to go through this as it provides step-by-step guidelines, and then you can use the practice case for a more hands-on experience. So besides the pivotal question, we'll also look at these different tabs where we're looking at red flags. So these are the flags that we need to spot while assessing the problems. We're looking at the key medical history information that we need to ask about. So when I'm talking to a patient with a transient loss of consciousness, what are the history information that are critical for me to ask about? And then we're looking at the key physical exam. So what is it that I want to focus on when I'm assessing the patient and examining the patient? What are the key diagnostics? So what are laboratory tests or diagnostic imaging tests that would help me work through these 19 differentials that I have? And of course, the clinical pearls. So the clinical pearls are basically the tips or the takeaway messages that help guide the diagnostic process. So I can always click on these different tabs and have more information on each of them. We're also, again, looking at this side of the diagnostic process. So besides the pivotal question, which is this syncope-related transient loss of consciousness or non-syncope related, we have the decision rule. So what are the clues that I want to look at to be able to make the decision whether it's a syncope or non-syncope? So with syncope, I have some clues. All three must be present. And then with non-syncope, any of the following could reflect non-syncope transient loss of consciousness. Again, all providing all the information in a framework approach. So after I look at all this, look at the red flags, the clues, what history I want to take and all that, I can start to refine my differentials. So from 19 differentials, based on the problem that the patient presents with, I want to break them down into a lower number, obviously. So the first answer that I want to, or decision that I want to make, whether it's syncope or non-syncope, based on the decision rule that I have here. Once I make the decision and click continue, I will have a refined number or list of working differential diagnoses. So now I'm looking at 7 instead of 19. And for each of these 7 possible diagnoses, I have all the details. I have the risk factors associated with these conditions. So if I'm thinking brainstem stroke, maybe I want to check if the patient has hypertension or diabetes, is a smoker, etc. We're looking at the associated symptoms. So what is it that the patient reports? Do they report nausea? Do they report vertigo, etc.? The signs, so more of the findings. Did I find out that they have tachycardia or facial droop? And then for every working differential diagnosis, I also have the workup. So if I click this link here, the workup, I will be looking at the very specific diagnostic tests that I need to run on my patient to be able to confirm or rule out that diagnosis. So if I'm thinking brainstem stroke, how can I confirm it? First, I need an MRI. It is the test of choice because it's the most sensitive and the most specific. If I cannot do an MRI, CT scan is the next choice, but it is less sensitive. And then other diagnostic tests, like, for example, the head impulse nystagmus and test of skew, HINTS exam, which is highly accurate at identifying brainstem stroke. It really provides you with the very specific tests to confirm this diagnosis. And then once we've completed looking at these differentials and the information related, at this stage, we can click next steps. And this is where we complete the problem module by bringing everything together. So we review the path that we followed. We look at references that are also linked there. These are all trusted McGraw-Hill references. And then from that point onwards, we can go to the practice case, which is the patient interactive encounter. So once we click practice case, we will land on this page where we will see a general overview of the patient. So for example, this patient is a 78-year-old male who presents to the emergency department with the chief complaint of transient loss of consciousness. That's all I know at the moment about this patient. And I'm going to use the interactive encounter, either using speech or text, to talk to my patient, ask them about their history, ask them about any details related to their chief complaint, and from there onwards, so just showing you an example, this is using text here. Hi, Mr. Morgan, what brings you in today? I passed out recently. Do you know how long you were unconscious? Not very long, I think. And you can keep digging into as many details as possible as you need. This interactive AI tool will keep answering any questions related to the case, related to the clinical condition, but it's not a random AI tool. So if students try to play around and ask like random questions outside the case, it will not answer. However, it will answer anything related to the clinical problem that we're looking at here. So after you've asked all your questions, you will move to this section where you can order different physical examinations. So maybe I need vital signs. Maybe I want to check, do some neuro exam, like check the eyes, the neck, whatever. So you can order whatever physical examination you need, as well as investigation. So under investigation, you will find different diagnostic tests, whether laboratory or imaging. However, at the beginning, you will have a basic set of physical examination and investigation options. And then as you move through the working differential diagnoses, you will have the option to order more specific tests based on the diagnoses that you're working with. So as a start, we start with general ones, and then we move into the specifics based on the working diagnoses. Once we've went through the different working differentials, we will end up with the final diagnosis. So after having ordered all the tests and received all the results, after receiving all the information related to the physical examination that I asked for, I will have sufficient information to be able to make my final diagnosis. In this case, my final diagnosis that I made for this patient is arrhythmias. When I select my final diagnosis, I also need to provide my confidence level. How confident I am that arrhythmias is what caused Mr. Morgan to have transient loss of consciousness, and why do I have this confidence level? I am highly confident, or it's a low confidence level that I have, and what is the reason for this? So after I've submitted that information, I will receive the feedback report that I mentioned earlier. And every time I complete a case, my report will be saved under past cases. So I can always go back and review these when needed. And that report will provide details on my reasoning. So based on the questions that I asked to the patient, based on the physical examination focus, based on the tests that I've ordered, I will receive tailored feedback. And of course, guidance on how to improve my future encounters. I'll show you an example of the report in a minute. So this is what a report looks like. This is a different one. This is a patient who presented initially with chest pain. The final diagnosis was unstable angina. The diagnosis that I've made was asthma. This is the feedback in detail, starting with the briefcase synopsis, going through the pivotal clues. So what is it that I'm trying to answer? What is the decision that I'm trying to make as a first step? The focused differential diagnoses, the must not miss, and the prioritizations, as well as case conclusion. So here you can see the working differential diagnoses, what I chose and whether it was appropriate or inappropriate to choose. So for example, myocarditis, It's a must not miss. The labs that I've ordered, were they appropriate or inappropriate? Like, why did I order glucose in urine when I'm looking at a patient with chest pain? Whereas, for example, things like troponin were definitely appropriate to order. Also related to the evaluation. So what is it that I've completed in the physical exam? What is it that I missed in the history taking? So very detailed, very tailored to help users improve their next encounter, and provide them guidance into how to go through the differential and clinical reasoning process in a more efficient and proper way. That's all for me, but I'm more than happy to answer any questions you may have.
Yep, thanks, Yara, to really walk through it. But before we go into any questions, I just want to highlight a few things about clinical reasoning is for clinical reasoning platform, it doesn't show you how to diagnose, it doesn't show you how to perform vital signs measurement, how to read the MRI reports. It gives you the answer to it because I think when it comes to clinical reasoning, the main thing about clinical reasoning solution is to help students to build up their critical thinking skills, not to actually by then they should be able to know how to read a report or how to diagnose the MRI, X-ray scans and CT scans, etc., or how to perform vital signs or even blood test reports from there as well. So the answers is there, but I think the steps is definitely needed for the students or the residents to actually perform that. Most of them should know by then. And critical reasoning platforms helps to build that skills. And one thing to really emphasize is clinical reasoning is before we have this solution, to me, I didn't know that clinical reasoning is such a big task for residents or even doctors to really comprehend. For example, for headaches or even for back pains, you have over 40 to over 100 over different diagnoses is out there. And imagine a student need to actually pick and pack, or like it means like finding different ways to find out what is this patient suffering from. And with this has a framework with two to five or six questions, you can definitely scale down from 200 or 100 over differential diagnosis to maybe under four or under five diagnoses that you need to work out from the patient. So it helps to give you the cognitive thinking skills, help you to streamline the effort towards how to diagnose a patient. And also, I think for hospitals, one thing that when we engage with our customers, they told us that actually there's a lot of money is being wasted because of doing tests that is not necessary. For example, like MRI is very costly for a patient. It's also very time consuming for the hospitals because the MRI scan can be an hour and it costs almost $1,000 in Singapore. So it's sometimes a patient might not even need that to even do with. That's the reason why critical reasoning skills is important. And lastly, I think a question that usually people brought up to me is, I'm using a point of care tool. How is this different from a point of care tool? The main thing right here is a point of care tool is to guide you through how to diagnose and test a certain disease. It gives you step by step and give you an answer towards a particular disease, but it doesn't train you how to think, what to ponder, what are the things that you should be thinking of, the critical thinking skills behind, how to eliminate of choices. This is all not being taught. And sometimes relying on a device is not the best way in some cases. And I heard one cases is a patient is actually the doctor actually did a right diagnosis, but the point of care to tell them otherwise, and the doctor choose to trust the point of care too. And end of the day, the diagnosis is different from what it is, and it's a wrong diagnosis. So sometimes it's technology is great, but definitely having the thought of skill, the skill of thought, knowing know how critical thinking skills can be helpful for you to eliminate different diagnoses. I think this is important from that as well, right? So thank you, Yara, for bringing us through the platform and do a walkthrough. It's very engaging. You just have any questions before we end today's session? We just want to open the floor for any questions.
Thank you, Kelvin. That was a really good wrap up.
No problem.
所有的，那想问一下，那有一些 case 是以 symptom 为主的，那最后，比如说我第一次去 brace 跟第二次，它的那个 differential 会不会都是 fix 还是固定？对，比如说我同样是腹痛，它最后出来我第一次 brace 跟第二次 brace 会不会每次出来最后有可能诊断都是一样？我想说，如果诊断都一样
，OK，
对。
Kelvin 要回答。
可以，我可以回答这个问题吧。哎呀，我们的这个 different diagnosis 每一个 problem，我们最少有3到4个 cases 不一样的 diagnosis，所以到最后有可能是不一样的疾病，就是那3到4个。可是他的 case 他会讲的很 generic，就是说我就是 我这边就是 chest pain，还是我这边就是腹痛。他不会跟你说很详细的东西，你就是要用那个 AIK 去掏，去问，去了解，再更深入的去了解他的问题，再做你的判断，做你的 investigation，还是做你的 submission of differential diagnosis，你可以从那边做。可是他的病例应该是每一个病例我最少有3到4个 case。
Kevin，我是王医师。
王主任要问你问题。
Kevin，我想请教一下，说，suppose 假设我们一个 fever 的发烧的 case， 那
对，
它会有4种不同诊断好了。那如果站在老师的角度来看的话，我可以，比如说我指定我要教其中一个 case， 我在事先挑选 case 的时候，我就能够知道这个 case 是哪一个 case 来做教学吗？
目前是 random，它是 random 3到4个 case，每个 problem 是 random 3到4个 case。可是你问我的话，我们有跟platform team 已经反馈到了，说如果老师要指定要这个 case，他是不是可以有这个 function？目前还没有，所以我现在目前的走法就是。学生就是要 random 来按到3到4次才看到哪一个 case 是那个你想用的 case，这是目前的一个问题。可是到最后以后的话，有可能我们会升级到可以 assign 哪一个 case，你要使用在你的课程里面，因为它的 case 的名字不一样的。它每一个就像刚才那个他看缺一个老人的那个 case，他的名字跟他的诊断是连在一起的，所以他的 case。如果你是换的话，它的名字也是会换的。
OK，
所以是会把这个功能未来有可能是建在 lecture 上面嘛，就是老师的身份上面有这个功能。
对，就是目前我们没有这个 faculty 的一个 functionality，说 assigning 是现在目前没有的。可是到最后的话，我们已经在跟 product team 是说有可能升级到有可能老师可以 assign 给学生做。可是目前还没有这个 function，所以还是比较是学生自己实习，拿到 report 了之后，再去跟老师去谈那个 report 中的里面的详细的问题，为什么我错了，哪一方面错了，哪一方面我没问到的问题，所以这个方面能行，还是学生可以倒回去那个diagnosis procedure 里面。一步一步的，因为 procedure 里面是一步一步的做吧，有可能3到4步，从这个3到4步，他可以一步一步的看他哪里出现的问题，自己去自修去self study 去看他的问题在哪里，再从那边改进。 也行。所以这个两个方案，有个是跟老师的互动，还是自己自修的互动，对吧？
我们有用中文去跟他对话。
他有中文界面吗？
他没有中文界面，但是他可以听中文。
对，讲话可以用中文。
对，我刚才在跟人家讨论的是，他是不是有中文的？
他没有中文界面，
就是 browser
对，他没有中文界面，但是你可以中文跟他对谈，
对，
然后也可以英文跟他对谈，但是他秀出来的那
都是英文，
对。
哎，想问 Kevin，
如果你是用中文打字的话，他回答的也是中文的，可是用字的方案，可是如果你讲话的话，就是用英文。目前啊，嗯，
哎，想问
我们也在试看，有可能建议是说全部也可以用中文，可是就是现在还是 beta，所以还是目前是用中文去打字。
哎，想问两个问题。第一个就是像你这个，它 update guideline 的 frequency 大概多快？哎呀，
我说
对不起，我没听到那个问题，可以再重复
说
吗？
那个
背光的那个
你的
textbook 或是背光的那些 guideline 的
update
的
frequency
大概是多久？
是吧？
OK，我们目前没有指定说多快我们会 guideline update 那个 guideline。可是如果我现在目前在了解这个 clinical reasoning 里面，它其实是比较偏入像critical reasoning 的那个思想的那个 process，他问的问题其实是导致比较很 general 的。所以它其实不是跟美国的 guideline 还是跟哪个国家的 guideline 很详细的做，因为他没有跟你说，他在里面没有跟你说你要先做哪一个。比如，我了解是说心脏病的吧，heart pain，有些国家会讲说会做一个 X 光才去做一个 MRI，可是有些国家就直接偏出了做 X 光，直接去做 ECG。所以它这个步骤的话有一点不一样，可是，在我们的系统其实不是 practice guideline 的一个系统，它是 critical reasoning 的 skills 的系统，所以它没有真正的把那个详细的 guideline 放在里面。
OK，另外一个问题是，我们可以知道学生的 progress 吗？就学生有没有进步啊？有没有，比如说老师
对对。
要跟学会知道吗？可以 follow 吗？还是
对，现在就是 lecturer faculty，这个是 faculty 的function，我们现在目前还没有，我们就是建议就是可以 assign 再有student progress report 的 feedback，可是目前现在学生只能可以看到自己的 progress report，他是可以看到的，而且我们这个 feedback report 是可以 download 到一个 PDF。所以你可以用 PDF 那个项目去看一下学生做的对不对，哪一份做对，哪一份做错。所以那个 feedback report 会导致是说一个 report 可以让老师跟学生互动的一个东西。可是
要不然
faculty function 还没有。
我再补充问一下哈，刚刚那个医师的问题
嗯，
哈，就是如
对。
果是没有固定update guideline 的时间，那以我们这个 system 来说，有没有一个 workflow 它update 的频率？本来你
我们现在目前是，如果有更新的话，我们就会有 update。可是我在讲的话，clinical reasoning 它其实不是一个 guideline platform，啊、它的是思想的能力的那个，他问的问题就是思想过程的里面的问题，是
是
还是不是？所以那个知识问题的话，其实改变应该不可能很大的，它改
是
变有可能是比较细。可是改变应该不会很大，因为判断一个 back pain 还是判断一个heart chest pain，其实应该也不会变得太多的。
但是如果以 content 的一个increase 来讲，
嗯。
你的 case 大概会怎么增？
对，我们目前是要放在600个 unit scripts，所以
是
如果你讲 content update 的话，其实分两批，一批
是
就是我们的 unit script 会增加，我们现
是
在从500多或600多，到最后有可能会更多一点吧。可是我不
是
要就是说over promise，可是我们那
是
个 unit script 肯定会增加。第二，我们的看的 cases 也会增加。目前我们要的 module 是差不多在30个 module，我们现在有15个 module，所以那个 module 还会增加，那个 problem 诊断也会增加。再来，我们的每一个 problem 里面最少要有3到4个 cases。如果到最后有可能会增加的话，有可能还会增加更多。可是最少到3到4个 cases，每个 problem 都会有。所以如果你看3个 case 乘以30个 module 乘以这样的话，就差不多整100多个 cases
嗯，
了。所
是
以目前我会慢慢的在增加。3月份的话会，我觉得会比较多 cases 会在里面，因为目前还在 beta 中，我们现在还在断断续续的把多 cases 放在里面，对吧？嗯，
Kevin 想请教两个问题，第一个就
对。
是我们现在 trial 的这些 platform，其实里面我看起来很多 case 其实都没有看到。
非
对，现在
完整。
目前你看到的应该是很 limited，因为我们现在再把多一点 cases 放在里面，所以你目前看到其实 cases 不多，最多好像是最多不到10个 cases，现在目前而已。可是，在3月份的话，我们会陆陆续续的放更多在里面了，所以我们的 ramp up plan 其实会有的。就是把3月份就把大多数该有的 cases 放在里面，再头来再增加更多。
那我再请教第二个问题，就是你刚刚
嗯，
说你们有30个 module 会再增加更多 module，那我想请教一下，你所谓
对，
的这个 module 是指什么东西 module？你这个 module 是
就是多一点 problem，因为目前我们在 Internal Medicine 里面是放到30个 module，到最后我们再要增加，最后的话有可能，我也不敢肯定，可是 Product Team 在增加是比较多一点 problem，还是会增加多一点的 area，因为现在目前你看到很多 problem，大多数是在 Internal Medicine 里面的 topic，有可能 other topic 会在里面。可是目前还是在 internal medicine 最为主，因为我觉得 internal medicine 在 medical 里面应该是算最细、最多 problem 的一个 subject area。after that after 这个之后，有可能到后来再增加多一点 problems，会在我们的目前的一个 pipeline 里面再增加。
OK，那你们的 case 有确定说大概3月就会都会有吗？
我们在目前看的 part plan 的话，应该在3月份最少应该是15个 problem 里面都有 cases 了，
OK
3月底
OK，
吧。嗯，
嗯，好，好，
对，
所以你的意思是说，maybe 3月底你们会是每个 module 里面都各有一个 case，或者是说每个
会有
problem
最少1个到2个，还是有些有3个到4个。嗯，
OK OK，好，
对，
好，谢谢。
这是目前我在看的 part plan，我在看，可以再看一下。
但是如果要完整，就是如同你说的，每个 problem 里面至少有2个到3个 case 的话，大概要什么时间才会有？
我可以再给你那个时间表，因为我现在目前没有在我的屏幕上，我可以有可能发给你我们的目前的 part plan，有可能会有改一点点，可是动应该是不太大，所
OK，
以那个幅度应该不会太大。
嗯，
再给我看一下，好像我
好
有，我现在等一下，三，我再看我多少个 cases，都有蛮多的。如果没猜错的话，最少有40个 cases 有吗？在三月
我
底，
我发给你应该是有46个吧，大概。
46个是吧？四十六
月底
个在几个 topic？1、2、3、4、5、6、7、8、9、10，在11个 problem 里面最少有40多个 cases。
，OK，
，OK，
这是我们的在3月底到4月的一个幅度，这个在这两个3到4月吧，这个幅
对对，
度里面，
发给我 Pop Plan 好了，好，再发给
对
我。
对，
可以。
有可能在6月、7月的话，最少应该是有75个 case，所以它的增加率会比较高。
好，
呃，对。
因为老师会想要知道说哪些 problem 是比较 ready 可以开始
对，我理
用的。
解，理解。我们也是很透明的跟你说，就是目前我们还在增加，可是现在应该是比较稳定的在增加了，所以它增加的速度会比较快一点。可
好
是我也不敢软答应啊。可是其实 Protein 给我的答案就是这样子。嗯。
OK，
还有人要许愿吗？有工人要许愿？
我想问的话，就是现在目前老师们用的 case 在教 CR 是怎么样教的？是不是用你们目前是拿出一个 case，从里面讲起，哪一个该关注，哪一个不该关注，是从你们的 case 走起的，还是会有一些比较一本书，还是你们会用几个 resources 来教，用Uniscripts 那边来教起呢？
嗯，可能会应该还是会用 problem 为 base 去做教啦。那只是
嗯，
说，suppose 老师在上课之前，总该要稍微知道一下这个 case 是什么，才不会
对
花太多
对
时间在课堂上，很多时间在那边点 bug，这样也不太好。就是
对，
说，如果我 initial 在上课之前，我可以很明确知道说我要上哪个 case 的话，会比
对。
较好，或者是说，也许3到4个 case 里面只有其中一个特别精彩，或者是哪一个特别
嗯
OK，我们就可以 skip 过这样子，会比较好。
嗯，对，我建议的话，因为我跟老师互动还比较多，我很多老师他们的建议就是跟我反馈，就是说在课堂上他们就会讲的比较多，在那个 unit scripts 还是会讲在那个 procedure，就在他的那个 beginning diagnosis test 第1到第4个步骤，第1到第5个步骤哪一个该看，哪一个不该看。可是在做那个AI 的 case 的时候，其实他们是用 TBL 来做的，就是把他那个 case，你们就进去登录里面，你们做一个组一个团，去把这个 case 做出来，你们拿到的答案我们再分享。所以其实那个 AI case，其实很多学校在用是比较用在做 TBL learning，他们教的方法还是会教比较多在那个 content。因为在做 CR 有可能教的时间也不长，所以有可能他们的花时间有些学校是10分钟，在每一堂课后节会教一点 CR，还是有些学校会有半个小时到45分钟，他在每一个月每一个礼拜里面会有一个 CR 这个步骤的一个 curriculum，他们会教 CR，单单教 CR。所以时间也不是说很多，所以他目前就是把 content 教起的那个 case 是用他们自己TBL 来做这个 case 的 AI。
因为我可以偷偷问一下吗？你说
嗯。
的 Hero 是哪些学校在用？
现在是在 trial，不在，还没有学校真的是在真的使用，因为现在没是在 beta 吧。有几个学校在菲律宾也在用，我有一个学校在韩国的也在试用。我有迪拜的也是有，I think yeah, I think some of the schools in Dubai are also doing the beta trial, right, at this moment. Yeah, I
Yes,
think
yes,
I
that's
think there's some of 比较 UAE 的学校还在做beta 的 trial。现在目前因为我们还在等3月份，所以其实很多学校要想看想买，可是有可能一阵我们
嗯，
在内地也是孙叶山也在看的是
对，
吧？
我们现在在中国大陆是新亚散，然后 Peking University，包括
对
Chinese University of Hong Kong，就是他们都在
CUHK
看。
对，
对对对，
嗯
嗯
他们
，QHK，
总体来说，他们对我们的评价还是很高的。包括孙亚散之前在 Hong Kong 参加一个CR 的一个比赛，他们大
嗯，
概用我们的 beta 版本先去 training 了大概1个月的时间吧。他们在那个比赛里面拿了第2名，第1名
哦，
是协和医院。
啊，肯定肯定，
对。
好，好，还有就是刚刚我的其他问题，
他唯一就是不能选科比，或者说眼科耳鼻喉科。
对，它是用 problem base 的。
对啊，
对，
那你就是从下 problem 处理。
对，但是他
然后自己去播嘛。
internal medicine 为主。对 ，internal medicine 为主。其实我觉得 OK 啦，initial 这样子就够了。
然后先不要那么。
对啊，就是这样。
因为我们 MPV 是要把 internal medicine 做的比较详细做好，对吧？因为 internal medicine 其实比较多 problem 都在 internal medicine 里面，所以把这个做起了之后，再看下一步骤的 update 会是什么。
就要看到这些怎么样，我来决定我上多少次课程的。
对，因为
可以上不久啊，而且一定要上去就才会有效果。我打算想办法看什么样的方式能够让。
Kelvin 主任说要看的内容才决定他课要开多久。
行，没问题啊，因为我们现在目前也可以也可以看课看，对啊，也可以窗面看，因为目前我听到的有些是差不多45分钟，因为澳洲有些学校是每个礼都到半个小时来做CR 这个课堂的课，有些学校就把它放在每天的课尾，就把它做一点，有可能15分钟到15分钟，10到15分钟的互动，来教 CR，所以每个学校有不一样的做法，所以也要看你们的学校是走向哪一项吧。
这个机会也提一下哈，因为三总会是我们的第一个 reference 哈，所以我们希望 local 端就是非常 fully support 他们哈，所以后续可能一些 training 的 material 可以给到硕瑞，我们要做中文的 training 跟中文的 user guide， 好，这个部分再麻烦协助一下。
对，没问题，因为我们我们会把英文班做好了之后，我们就把它翻译给中文。现在目前好像 Jasmine 在做的就是用 AI 做一点 translation，所以讲出的那个语音也是中文的。
目前是这样的，简体中文的版本，目前我开始在审核，已经快差不多了。然后接下来我会把简体中文的版本发给你们，然后你们可以去改成繁体中文的版本。
Kevin, we need traditional Chinese medicine rather than simplified Chinese editions, right?
Yes. So we will try to translate to traditional Chinese.
Thank you so much.
No problem. That's for sure.
好。OK 了。哎，
线上有什么人有问题吗？
问题。你看要谁？这是什么？看一下这里，你点下面那个才余会址。
线上都比较安静点。
线上的师长还有没有什么问题要询问的？
有没有要提出问题的？没有吗？好，那应该，那个晚上有叫他们填。
对，帮我来写。那请老师们，如果在线上老师们帮我上那个留言那边写一下那个今天的签到表跟课后满意度问卷哦。
有填了，我们才会寄那个录影档哦。OK， 好，那差不多就这样子，现场没有其他的问题了，谢谢。
谢谢你大家，谢谢。Thanks for everything. Thanks, Yara.
Thank you.
Bye.
Thank you. Thank you so much. Have a great evening.
谢谢大家，谢谢大家。
对啊，他已经没力气了。